All right, let's get right to it. Welcome to This Explainer, Focused Learners. If you're prepping for your exams and you need the absolute highest yield information on geriatric pain management with zero fluff, you are in the exact right place. We are strictly covering exam-critical material straight from the source. Literally no bull, just the comprehensive facts you need to understand the material and totally crush your test. So let's get right to work.
Okay, let's dive into this and just quickly map out the clinical workflow arc we'll be using as our mental study guide today. We'll kick things off with patient concerns, then move right into assessing geriatric pain. From there, we'll break down pharmacologic interventions, face some analgesic realities, climb the WHO analgesic ladder, and finally wrap the whole shebang up with non-pharmacological interventions.
Starting right off with Step 1. Section 1. Patient and Caregiver Concerns.
We're going to rapid fire through these psychological barriers, because honestly, these frame the classic patient presentations you're going to see in clinical scenarios and definitely on your exams. These are the things that actively impede proper pain management. Watch out for patients avoiding care entirely because they're terrified of getting a serious or life-threatening diagnosis. You'll also frequently see massive fears related to addiction or patients who are just super concerned about sounding like a complainer. A lot of older adults want to remain stoic. They kind of feel like expressing pain makes them look weak. In some cases, there's even a cultural or religious perception of pain being an atonement or a punishment. Wild, right? You'll also run into this stubborn belief that strong analgesics are just strictly reserved for terminal cases. And finally, never ever forget the heavy stigma associated with opioids and other prescribed pain meds. Seriously, memorize these psychological profiles. Test writers absolutely love using them as primary barriers in those tricky exam vignettes.
Moving right along to the next clinical step. Section 2. Assessing Geriatric Pain.
Okay, I'm flagging this entire assessment phase right now as highly testable material, so focus in. First up is the absolute gold standard, the OPQ-RST pain assessment. Whenever you're faced with a geriatric pain assessment question, this acronym is your foundational framework. It covers all the essential bases of a comprehensive pain history. Please do not skip over this in your studying. It's a non-negotiable memory item for sure.
Now, what's really interesting here is how we handle appropriate pain scales for individuals with cognitive impairment. These two specific scales are essential exam fodder. We have PAIN-AT, which stands for Pain Assessment in Advanced Dementia. We also have PACSLAC-2, the Pain Assessment Checklist for seniors with limited ability to communicate, 2. If your exam vignette mentions a patient who simply cannot communicate effectively due to cognitive issues, test writers fully expect you to instantly recognize and select these two acronyms in your assessment plan.
I want you to pause for a second and really consider these person-centered care questions. Exams absolutely love to test your ability to look at the holistic patient picture. You got to ask things like, what is their actual acceptable level of pain? Is the person even interested in self-management interventions or maybe complementary and alternative medicine? Are they actively worried about the adverse effects of medications? And practically speaking, would a referral for pain management be helpful, or is it more appropriate to consider a referral for physical or occupational therapy? These are the exact specifics that turn a basic textbook assessment into top-tier person-centered care. And let me tell you, exam writers love to bait you with multiple-choice answers that totally ignore the patient's personal goals. Don't fall for it.
All right, transitioning into the medical side of things. Section 3, Pharmacologic Interventions. Get ready to take a screenshot.
So we've got three main classifications to master here. First, non-opioid analgesics. Everyday examples include acetaminophen, non-steroidal anti-inflammatory drugs, your NSAIDs, and aspirin. Second, opioid analgesics. These are the natural, semi-synthetic, or synthetic drugs that relieve pain by binding to multiple types of opioid receptors right in the central nervous system. Finally, adjuvant analgesics. Now, take special note here because adjuvants are a classic exam trap. Why? Because these are medications that have a primary indication entirely other than the treatment of pain. We're talking antidepressants or anticonvulsants, but they actually effectively relieve pain in some specific conditions. Don't let an exam question trick you into thinking an anticonvulsant can't be an active part of a pain management plan. It's literally one of their favorite ways to catch you off guard.
Which brings us to Section 4, Analgesic Realities.
Listen, I am explicitly warning you right now. The next three definitions are constantly confused on exams, and you need to know the exact boundaries of each one. First up is medication tolerance. So the crucial point here is that this is a physiological protective mechanism that helps the body become accustomed to medications so that adverse effects gradually diminish. Pay incredibly close attention to the timeline here. This usually occurs during the first several days to 2 weeks of therapy. It's entirely physiological and it is highly time-dependent.
Now, let's heavily contrast that with dependence. Dependence is a normal physiologic response manifested by the development of withdrawal symptoms when an opioid is suddenly discontinued after being administered for more than 2 weeks. To easily differentiate this from tolerance on an exam, just lock on to the key keywords withdrawal symptoms and the need for an opioid to be tapered down to help prevent those exact withdrawal symptoms.
And finally, we have addiction. Unlike the normal physiological responses we literally just covered, addiction is a chronic disease. It comes with biologic, neurologic, and psychological characteristics. On a test, you are actively hunting for one or more of the following in relation to a drug: craving, compulsive use, a total inability to control its use, and continued use even when harm occurs. Let me repeat that: compulsive use despite harm. That is the major red flag distinguishing addiction from mere dependence or tolerance. Keep those definitions strictly separated in your mind.
Moving into a huge clinical algorithm, Section 5, the WHO analgesic ladder for pain management. Okay, let's move to this escalation protocol and see how this builds systematically, because it is widely tested. Step 1 is for mild pain, meaning a pain score of 1 to 3. Here, you're using non-opioid analgesics first, with Tylenol being the absolute first-line treatment. Moving up to Step 2, which covers mild to moderate pain with a score of 3 to 5. You still continue the non-opioid analgesic for continuous pain relief, but now you add a medication specifically for breakthrough pain, like Lortab, Tylenol number 3, or Percocet. Finally, Step 3. This is for persistent or worsening pain, scoring 7 to 10. At this top step, you consider an opioid around the clock using a controlled release formula. Plus, you use something for breakthrough pain, such as opioids with a shorter half-life. You really need to hammer home these specific pain scores, the baseline meds, and the breakthrough additions required at every single step. Bringing our clinical workflow to its final stage, Section 6, Non-Pharmacological Interventions.
Let's quickly review this comprehensive list of non-drug therapies. We've got exercise and physical activity, cognitive behavioral therapy, TENS or PENS, which are transcutaneous or percutaneous electrical nerve stimulation. We also have acupuncture and acupressure, massage with or without aromatherapy, therapeutic touch, mindful meditation, guided imagery, relaxation methods, and even Tai Chi. Remember, multimodal pain management, meaning combining the pharmacologic steps we just locked down with these non-pharmacologic interventions, that is the clinical gold standard you should absolutely always aim for in your exam answers.
As we wrap up this explainer, I want to leave you with a provocative question to test your true synthesis of this material. So what does this all mean when put together? If you had a geriatric patient with cognitive impairment exhibiting a pain score of 8, how would you synthesize the pain ad scale, the WHO Step 3 ladder, and complementary interventions to deliver comprehensive person-centered care? Take a moment and really think through that scenario. It forces you to combine assessment, pharmacology, and holistic care, which is exactly what the hardest, highest-level exam questions will ask you to do. Master this intersection, and you are well on your way. Best of luck on your exams, and keep up the highly focused studying. You've got this.